Welcome to Progenesis Academy webinar. This is session number 17. Today's topic is about infertility, causes, diagnosis, risk, and treatment. It is my pleasure to introduce our panel of fertility experts. We have with us Dr. Rodi from Pacific Fertility Center from Los Angeles. We have Dr. Roseff from IVFMD, Florida. And we have Dr. Werlin from Postal Fertility Medical Center and Dr. Jones from Conceive Fertility Center. Thank you so much for joining us.
Thanks for having us.
In the last webinars, we have about now number 17. We have been asking about COVID-19 a lot because back then the pandemic was at the peak. Now we are seeing a second wave in certain states. And I would like to know from you guys about what we know about COVID-19 as far as impacts on pregnancy and delivery. And I know that we have a previous discussions, and Rodi made a comment. In the last time I checked the literature, there was a study looking at 16 pregnancies, and they've seen that the deliveries, there were no impacts on deliveries, but on the placenta, there were some sort of minor lesions in those pregnancies, but no obvious impacts on deliveries. Do you guys have any additional information we could, educate the patients on the risk? And I will start from Dr. Roseff, and then I'll go from right to left.
I really don't, honestly. I look at the literature, and a case report comes out of here, and a case report comes out of there, and a small case study comes out of there, and they're just, the numbers so far are not, I don't think they're large enough to really make any definitive conclusions. Every time a little study comes out, someone looks at the study and says, well, their data are faulted based on this, and they should have looked at this, but they didn't, and they eliminated that. So it's really hard to piece it together. It's, again, very preliminary, and I really don't have any conclusions on it at this point in time.
Very good. Thank you so much. Dr. Rodi?
Well, at least there's somewhat news that makes us a little bit more comfortable with respect to delivery and the pregnant patient having COVID, in that at least with respect to other viral illnesses like rubella or Zika virus, at least so far, most of the studies have shown that there's been no negative effect on the fetus with respect to the virus, whereas with things like Zika, they had microcephaly, neurological problems, things like rubella, where they could develop congenital deafness. So from that perspective, it's encouraging. Obviously, there has to be much more data that's put together, since we're still really in the infant phase of the process. But at least that gives us some encouragement that we're at least proceeding along a reasonable path.
Thank you so much. Dr. Rodi?
Well, I think there are a couple issues. One is that we don't have very good data for first trimester exposure yet, just because the first pregnancies would have been in January of this year. So any pregnancies that haven't been able to be watched for the full 9 months, I think it's very difficult to say, what is going to be. So I think there's a lot still unanswered. Certainly, I'm reassured that it's not, the impact on the patient isn't even as bad as influenza, which is great, because influenza and pregnancy don't go well together at all. So we're advised to let patients know that they probably will have a worse course than if they were non-pregnant, but it's not severe. And so that it's not in the same league as many of the others for the patient. And as Dr. Werlin mentioned, not for the fetus.
Some of the early reports coming out of China in the beginning of the pandemic looked at women who were severely ill, third trimester delivered, and those early reports showed the babies that were sick in a similar way to influenza. I don't know if everybody remembers that report.
Thank you so much. Dr. Jones, any comments?
I just have to echo the other panelists. We don't really have a lot of information. I think most of it is case studies and anecdotal, what I hear from the local OBs in delivering COVID patients. And I am.
Very good. Fantastic. We have some questions that we have received from patients. We're going to start taking some questions. William, can you give us a couple of questions and then we can run them through the panel?
Yes. So the first question was from a patient, Natalie. She says she has a couple questions. The first would be about PCOS, hyperplasia, blocked fallopian tubes, hormone imbalance, and she was wondering, how can all of that affect infertility, and how can she reverse the issues, not only to conceive, but to be healthier? She says that she's 35 years old with PCOS, and so she was wondering exactly how does that affect her fertility? And she also wants to know what exactly is hyperplasia, and does it have a cure, and how does that affect her fertility?
Very good. Dr. Roseff?
Many women with polycystic ovarian syndrome are overweight or obese. And obesity is usually associated with high body fat. When I see any fertility patient in the office, we have a device that actually measures total body fat. Body mass index, BMI, is often used by most practitioners, but it can be misleading because it's a calculation of height and weight. And if we have a patient who's 6'2" and 200 pounds, that might be okay, but we can be 4'2" and 200 pounds, and that's not okay. So weight is misleading. BMI is misleading sometimes because muscle, I have patients who are bulky with a lot of muscle, muscle's heavy, and they have a BMI of 30, which is classified as obese, but they're really in very good health, and all of that BMI is muscle. So we measure body fat, and fat does some things. We used to think fat was fat, and fat just sat there, and we had a little, a lot, or somewhere in between. But we now know that body fat is like a factory, and one of the things that the body fat factory produces is estrogen. And if we have a lot of body fat, then we can have a lot of estrogen. Estrogen stimulates the lining inside the uterus and makes it proliferate, makes it grow. And if a woman has high body fat and high estrogen every hour of every day, all the time, and especially if she's not menstruating and having regular periods and shedding the lining can overgrow. And an overgrown lining over time is something we call hyperplasia. If we leave hyperplasia alone and we don't do anything about it, over time, it can become precancerous or it can become cancerous, endometrial carcinoma. So the question Natalie had is the PCOS, if it's associated with obesity, high body fat, irregular or absent menstrual cycles, which often will go along with PCOS, it can predispose to hyperplasia. There are different kinds of hyperplasia. There's something called atypical hyperplasia, it's complex hyperplasia. And the bottom line is if you do nothing, it can turn into cancer. So when I have a patient with these findings, one of the critical things that I tell her she has to do is she has to get healthy. She has to lose body fat. And I can't tell you how many PCOS, obese, high body fat patients I see who come to me whose doctor just put them on progesterone, just put them on Megace, just put them on Provera, or did a DNC to scrape out the uterine lining, and never mentioned anything about losing weight or losing body fat or getting metabolically healthy. So it's that's hopefully that helps to answer the question about what hyperplasia is. Some of the things that can be done would be make sure you don't go more than 2 months or so without a menstrual period, preferably every month. And if you're obese or have high body fat, you meet with someone, whether it's a nutritionist, dietitian, personal trainer, get information about getting into better health. And that often can help, usually does.
Very good. Thank you so much. Dr. Rodi, any other comments on how to deal with situations like that with PCOS and hyperplasia?
Well, I think the challenge is to get the patient to change her lifestyle. I mean, and I do think that even though many patients don't, that it is worth discussing, because if you can get them to lose weight or body fat, it will make a big difference, not only in their chance of conceiving, but also in the reduction of miscarriage and in the reduction of hyperplasia. So I agree with all the comments that were made before me.
Very good. Dr. Werlin?
Well, I absolutely agree with what's previously been said. And I would just add that critically, if you've made the diagnosis of, first of all, many people make a diagnosis of PCOS that truly don't have the disease. But if you have it, it needs to be treated. If you're interested in fertility care, then most commonly the treatment of choice would be something like a drug like metformin. If you're not interested in fertility care for exactly the reasons to prevent the hyperplastic part of this, you'd want to be on a birth control pill. I think part of what we try to do when we see patients like this is to evaluate them in totality, as you've said, with weight loss programs, putting them on appropriate medications, because once you begin to stimulate them and ultimately get eggs from them, a lot will depend on their quality based on how well they've responded to their treatment. So, and ultimately you're hoping that the quality of their eggs will give them good quality embryos that will ultimately yield a good quality pregnancy.
Thank you so much. Dr. Jones?
I agree with the other panelists. I do think that weight loss is a part of the conversation. I have someone who tries to lose weight myself. I understand that it's very hard. And so we definitely have to give the right tools and work with the patient and listen to the patients on how they feel also about their weight. And if weight loss is difficult, getting them to different providers and talking about bariatric surgery. In the interim, using things like oral contraception pills and even intrauterine devices while they're not attempting to conceive can help with the hyperplasia and reversing it. And also I let patients know that weight is not an end-all be-all. There are many sizes that can have children. And if weight loss is not the ideal for that patient, then proceeding with care can also take place.
Thank you so much. Let's go to the next question on the list. William, if you can give me the second question, and then maybe we can take some of the questions that are asked live. I think there's one question on sperm, but let's take the second question first.
Yes, so the second question is from a patient. She says she's almost 43 years old, and after 5 years of assisted reproductive technology, she's done 7 transfers of her own embryos. Some of them were PGS tested and some were not. She had been recommended to try egg donation. She's interested in learning more about the pros and cons of egg donation and the unforeseen complications of this procedure that might occur. And she says that she's had a lot of doctors mention that utilizing donor eggs is the easiest way to make women over 40 pregnant, even if her own egg count is good and there are some good embryos that result from her eggs and her husband's sperm. And she has heard that this alternative also comes with multiple risks and factors that should be considered. What are your thoughts on egg donation?
Okay, very good. Dr. Roseff?
Well, if somebody's 43 years old and has decent quality, genetically normal embryos and is either not implanting them or miscarrying them, I would, first off, before moving on to donor egg, I would suggest a second opinion and perhaps a third opinion. Because theoretically, if you have a good intact uterus, if your body is in good health and good condition, if the man who produced the sperm is healthy and the woman is healthy, and we have a genetically normal, good quality embryo, it should work. So it almost sounds to me like something may have been missed, something may have been overlooked or not done to optimize the odds of success, because I frequently get patients for second opinions and third and fourth, and I had a patient where I was the seventh opinion about 2 weeks ago. And I saw a patient today who was at another IVF facility, went through 2 failed IVF cycles, and was told she needs an egg donor, and she clearly does not need an egg donor. So I would suggest another opinion. But since the question is asking about egg donation, if someone does move on to egg donation, I think we'll probably, all the panelists will agree that there are pretty much 2 types of egg donors. Egg donors are what we now call a fresh egg donor and what we call a frozen egg donor. A fresh egg donor is a young woman over there who has been screened for all kinds of things, genetics, infectious diseases, egg quality, egg quantity, and so on and so forth, and has been accepted into a program, perhaps through an egg donor agency, where she is now qualified to donate her eggs. A fresh donor goes through injectable fertility medicine stimulation to stimulate a whole bunch of her eggs to grow and mature and develop. We typically synchronize that with what we call the recipient, where we're prepping her body with hormones to make the uterus as perfect as possible at the right place at the right time, to synchronize that with what the egg donor is doing to stimulate the eggs to grow and mature. The eggs come out of the donor's body as an egg retrieval. We fertilize the eggs with partner sperm or sperm from a sperm bank, if that's the situation, to grow embryos for at least 5 days in our laboratory, sometimes 6 days, and on occasion we even grow to day 7 to an advanced stage of embryo development called blastocyst. And that is synchronized time-wise with the uterine preparation for you, the patient, where now when the embryo is ripe and ready, we do the embryo transfer to the uterus. The alternative to that is what we call frozen egg donor. These are young women who went through all the screening processes, went through the fertility drug stimulation to get their eggs to grow and mature and develop. Their eggs are retrieved, taken out of their bodies, and those eggs are frozen at an egg bank. And we have you, the patient, go to the website or websites for the egg banks that we work with, and you look at the pictures of the donors and you look at their profiles, their hair color, eye color, skin tone, ethnic background, hobbies, likes, dislikes, and you say, I really like her and I want her eggs, and you purchase the eggs. The potential benefit for that using frozen donor eggs is that the cost is typically lower, because all of the testing that's done to screen for infectious diseases, drugs, alcohol, genetics, and all that, it's already been done. It's all off the table. The injectable fertility drugs to stimulate all those eggs to grow and mature, you're not paying for that like you are with a fresh donor. The anesthesia, the egg retrieval, it's all been done. So you're basically purchasing the eggs. The frozen eggs are, if it's an outside egg bank, they're shipped to our IVF laboratory frozen. And then again, I give hormone preparation to prepare your uterus to make it as perfect as possible for pregnancy. at the right time. We thaw the eggs, fertilize the eggs with partner sperm or donor sperm, whatever the situation calls for, grow the embryos to blastocyst, and do an embryo transfer. I know the other part of the question asked about, you know, what are the risks, what are the potential problems and all that. And since I've spoken a lot to answer this question, I'll let some of the other panelists, if they prefer, to discuss some of the potential problems.
Very good. And I will pass that to Dr. Rodi. Any potential risk using egg donor? And is egg donor the right way to go?
So I agree that if this particular individual has euploid embryos that and she has not gotten pregnant with them, that it is time to evaluate her uterus further and make sure that implantation can succeed. So it is possible, and most patients would prefer to use their own eggs, so that it is possible that this patient could still use her own eggs. I look at egg donors a little bit differently, in the sense that I very rarely will match a donor in a fresh cycle, so that for many, many years now, I've frozen the embryos and then transferred the embryo in a frozen embryo cycle. The other thing I've done for a couple decades at least now is that most of my egg donor recipient pairs know each other. And that has been really helpful in these days when anonymity is very hard to promise, that I haven't promised that for a very long time. And I find I'm very happy with the notion that people know each other, they're not a commodity. We don't have the logistical problems of keeping people separated. And my experience with couples who have done it both ways, they have uniformly preferred having met the donor. So, so that takes away some of the problems with anonymity right now. So I would say that has worked for me. The complication for the recipient or the woman who's going to use the donor eggs is really, if anything, less than using her own, because the chance of miscarriage is likely, even in the face of PGTA, less. So I would say that the issues are more psychological, and that with good psychological preparation, it should be a very successful treatment plan.
Thank you so much. Dr. Werlin?
Well, I certainly agree with the other two panelists. There's no question about it. The couple of things I would say, first of all, with respect to the woman herself who has done a number of cycles, I agree with Ingrid. If she has a euploid embryo and has not achieved a pregnancy, then it is an excellent idea to further evaluate her uterine cavity. And certainly one of the things that you can do, effectively by the time you get to embryo transfer, there are really two critical factors that play a role. One is going to be the embryo, and the other one is going to be the uterine environment. So if you've controlled the embryo issue by doing PGTA and know in fact that you're putting back a euploid embryo, that's one factor you can control. The second factor, which is the uterine environment, typically, as Ingrid said, we really don't do any fresh embryo transfers. All of our embryo transfers are done in a frozen cycle because you can use hormone replacement to control that cycle. But even more importantly, when you do that, we typically, and now we do it almost on a regular basis, we do an endometrial receptivity assay where you can actually get a better indication of what day you can actually do the embryo transfer. So I think that's an important thing to utilize. Now, with respect to the other facets that you were talking about, one of the ways when you do a fresh egg donation, one of the things that you can use is a directed fresh egg donation, which is really what Ingrid said. And of course, that could be a younger sister, a younger cousin, a younger niece, someone that you know that hopefully you have at least some genetic relationship with this person. The problem, of course, is that you can't really control what happens down the line. And as everybody has said, there's no question that everybody who uses sperm donation, egg donation, we always have them see our clinical psychologist to, in fact, make sure that everybody's on the same page before you do this so that you get the best outcome that you can. And the only last thing that I would say is when you use the egg donor bank as opposed to using a fresh egg donor cycle, the biggest difference is that with the egg donor bank, you get a specific cohort of eggs, typically about 6 to 8 eggs. Whereas when you do a fresh stimulation, however many eggs that donor gets in that cycle belong to the patient. And those are critical factors that you just have to take into account.
Thank you so much. Dr. Jones, if you can address the same points, but also give us the perspective of risk assessment when it comes to COVID-19. So, you know, fresh retrieval versus frozen eggs prior to the pandemic. Is there any relative differences there?
So with regard to the first part of the question, I agree with everyone. I think that patient in particular, a second opinion and definitely delving in further to what's going on with the uterus. And I think we sometimes miss that if you have recurrent implantation failure, it is similar to recurrent pregnancy loss. And so we have to kind of think outside of the box and not, you know, if you put in a euploid embryo and it doesn't stick, the biggest risk of using donor eggs is that you would do donor eggs and it still doesn't work. With regard to COVID-19 and pregnancy, or now that we're in this new COVID-19 era, a fresh transfer, I think, would be a big gamble because our transfers based on someone's COVID testing. And so we do COVID testing for the intended parents, and we do COVID testing for the donor if we're doing a fresh cycle. So to do a fresh transfer, if that's the question, while we're doing an egg retrieval, it's possible that that patient would turn positive and then have to delay. And so that would be a loss of resources and a loss of kind of that hope for that fresh transfer.
And if a patient is trying to get a donor, would you make any recommendation whether those eggs can be, you go for a frozen egg that has been retrieved, let's say 6 months ago versus eggs that have been retrieved recently? Is there any recommendation on that side?
You know, I think that's a very complicated question. Prior to this, we thought that all of this started back in maybe December, but I really couldn't say that we could be safe to say that someone who wasn't tested before, if that's the question you're asking, isn't COVID positive or wasn't COVID positive. They probably didn't have any symptoms, but we know a lot of patients don't present with symptoms. So that is a difficult, very difficult question. But a patient using fresh donor eggs would at least have a little bit more reassurance, though the false negative rates of some of these tests aren't great. But at least they had the opportunity for testing and screening negative.
Thank you. Any comments from the panel on the same question, whether there is any additional risk if someone goes for a fresh egg retrieval versus something that has been done a few months ago?
I don't think anybody knows the answer to that. It's just too soon to know.
Okay.
I will say, you know, I talked about fresh versus frozen. 99+% of our patients at IVF MD are doing frozen donor egg. So it's, you know, it's pretty rare these days that we have someone do a fresh stimulation in a donor.
Thank you so much. Mia, I'm gonna take some questions from your side, maybe one question or two, and then while we're doing that, maybe William, you can take the live questions and just process them in the meantime. Mia?
Yeah, I'll read a question. So yeah, we have a question here from Hillary. She is 42, and she's asking if there's a way to improve egg quality after age 40.
Let's start from Dr. Werlin this time.
Well, that's a very good question. The thing that most people have to remember is that you're born with all your eggs. As you age, the most critical factor that we see with respect to fertility issue is the age of your egg. And as you age, the genetic material within those eggs break down, they become less viable, less functional, and less likely to be successful. So are there things that you can do that will help you to get potentially a better quality egg? Well, I mean, I think there are. You can do things like acupuncture, for example. And in doing a process like acupuncture, there's definitely data in our literature that shows that acupuncture can be beneficial with respect to IVF outcome. And one of the ways that it probably works is that they believe that they have the ability to divert blood flow to the vital organs. So theoretically, if you could divert your blood flow to the ovary, you'd get better delivery of oxygen, better delivery of nutrition, better delivery of the hormone to the developing follicle, and potentially get a better quality egg. So a very real factor that could play a role. There are also substances that people recommend, like CoQ10, DHEA as reasonable things to use, although the data on whether or not they're really beneficial is unclear. Living a healthy lifestyle, without question, is an important factor in that one should not smoke, minimal alcohol consumption, minimal caffeine consumption, a well-balanced diet that will help you. All of those things can be beneficial. But the reality is that a 42-year-old egg is a 42-year-old egg, and as much as you can do to improve it, it's still a 42-year-old egg.
Thank you so much. Dr. Rodi?
Well, I think one of the issues, just to add to what Dr. Werlin said, because I agree with what he said, is that there is a range of fertility especially for women between the age of 35 and 45. There's much more variability from one woman to the next than there is in a 25-year-old or in a 50-year-old. So part of determining how likely it is that a particular 42-year-old will get pregnant is to evaluate her ovarian reserve, because clearly there are women who are 35 who in an IVF cycle will make 2 eggs, and there are women who are in their 40s who will make a lot of eggs. And then the next step is once you have a lot of eggs, is to see which ones of those make normal embryos, or at least normal to the degree that we can test them. So clearly women who make more eggs will have a better chance of having some euploid embryos in this process. So it's helpful to have the concept that women's fertility goes down with age, but I think it's very important for the individual not to be bound by averages and to be evaluated herself.
Thank you so much. Dr. Jones?
I think they've pretty much covered it. I think that what Dr. Rodi said was very important about the variability and not letting age alone discourage you. I think the testing is very important before you make any assumptions, although rates are lower, definitely knowing where you stand in that statistic is best.
Thank you so much. Dr. Roseff?
Yeah, I mean, as the last person to answer, it's pretty much all been said. I will say that the age factor is the most limiting factor in the odds of success, especially with in vitro fertilization. When I have a 32-year-old with not very good eggs based on ovarian reserve testing, and I do treatments, I have all of my patients undergo acupuncture. I take a very holistic approach with all of my patients. We have a world renowned nutrition, exercise, physiology expert who works in our practice. And I have my patients work with her to become metabolically the best that they can be. But you can't negate the age. So we get them healthy. I have supplements that I recommend for my patients, like Dr. Werlin had said, specifically mostly antioxidants, things like alpha lipoic acid, things that we don't know with any certainty that can help, but they certainly can't hurt. Acupuncture, big on that, but there is the age. And when you're 43rd, when you reach your 43rd birthday and we get those eggs and we create those embryos and genetically test those embryos, on average, when you've hit your 43rd birthday, 85% of your embryos on average are chromosomally, genetically not normal. And so you can get all these amazing eggs, looking eggs, you can get these embryos, and if we get you to grow 4 advanced embryos, blastocysts, and we biopsy and genetically test 4 of your embryos on day 5 or day 6, and 85% of them on average will be chromosomally not normal, then 85% of 4 is 4. So we still don't really have a lot to show for it. So age is really a huge factor.
Thank you so much. We're gonna take a question live on the chat. David was asking about sperm counts, low sperm counts, and what do you do to improve it? That's for you, Dr. Jones, if you can answer that question.
Well, I think we need to figure out exactly what the issue is. I do refer a lot of my patients with low concentration of sperm to a male fertility specialist so that we're not just ignoring it. It's very easy to do IVF on patients or do IUIs, but to know the underlying factor would then lead to what we can do to help improve it.
Very good. Any other comments from the panel on low sperm counts and how do you address it?
Yeah, you have to find out why it's low. If it's, I do blood testing to look at the hormones that go from the pituitary in the brain to the testis to stimulate sperm production. If those hormones are low, then we can boost those hormones with medication. If there's a dilated vein that can be around the testicle, it's called a varicose vein. It's called a varicocele. If a man has a varicocele and the situation is proper for both the male and the female partner, then treatment of the varicocele surgery certainly has the capacity to improve the sperm. When there's very, very low sperm counts, sometimes it's chromosomal, genetic. There's a blood test that looks at something called a Y chromosome microdeletion that drills down to the sub-level on the Y chromosome that is responsible for giving the genetic signal, make sperm. And if a man has a Y chromosome microdeletion, we can give him hormones, you can correct the varicocele, but that genetic underlying factor is gonna make the sperm low. I see horrible sperm in men who are morbidly obese a lot of the time. And again, we really focus on lifestyle a lot in my practice in Boca Raton. So the counsel about proper health, diet, exercise, weight loss. High heat exposure can cause bad sperm. I have guys who go to a sauna 3 or 4 nights a week just to relax. And chronic high heat exposure, hot tub, jacuzzi, sauna can cause bad sperm. So we have to do that. I see people smoking cigarettes, smoking cigars, vaping. There are a lot of people now, whether it's recreational or medicinal, a lot of people using marijuana. We can probably have a full discussion about marijuana and its potential effect, but I will tell you that I see guys who smoke a lot of pot tend to have sperm issues as well. So we really have to take a history. We really have to get the examination done. We have to do some testing, try to get to the bottom of why the sperm is bad to see what we can do to improve it, rather than just pluck a sperm and inject it with a microneedle into an egg, ICSI it to create an embryo. why not level the playing field, get to the root of it, see if we can correct it, and then perhaps enjoy natural conception.
Thank you so much. We have another question from the live chat from Cecilia, who was asking the fact that you freeze the eggs and then you thaw and then you fertilize and then you freeze the embryo and then you thaw to transfer. Isn't that too much on the egg and on the embryo? And I'll take any speaker who anyone from the panel who wanted to answer that. Dr. Jones, you're smiling, maybe.
I always smile, it's my resting face. So, yeah, you know, I guess the proof would be in the outcomes. So, you know, egg freezing has definitely, it is a worthwhile way to preserve someone's fertility. If it did not lead to live births later, it would not be a viable option. So yes, freezing them and thawing them and then creating embryos and freezing those embryos would seem like a lot, but those embryos do thaw well, even if they came from a frozen egg, much like if we used an egg donor. So I think the proof is in the live birth rates, and it is a great option.
Any other comments? Thank you so much.
Yeah, I would just say, I would definitely agree with Tiffany, but I would certainly say that, again, as we emphasized before, probably the most critical factor that you're looking at is the age of the egg when you freeze it. And it's different when you freeze eggs between the ages of, say, 19 and 32, which may be how they freeze donor eggs. As opposed to freezing somebody who's 39 years old. There's a difference with that. And it will have an effect on what the outcome is. We have some very good data with respect to freezing and thawing eggs in young women, but there's not as much good data available in women who have advanced maternal age. But again, I think probably the most critical factor with that is the age of the egg. But if you thaw the egg and it thaws well, you inject it, it fertilizes well, ultimately it makes it to the day 5, day 6 stage. And if you biopsy it and it comes back normal and you've frozen it, then I think you're in good shape.
Thank you so much. We have a question, a live question from Aisha. Let's connect to Aisha. Riley, are you there? Can you make that happen?
Hi, Aisha.
Hi.
Hi, you're good to go.
All right. Hi, guys. My name is Aisha. I'm just a recently 29-year-old woman. I'm having my first transfer tomorrow. I have PCOS. Thank you so much. I have PCOS. Just a little bit about my background. I was previously 310 pounds. I lost weight, and I've been with my husband for 10 years. I never got pregnant until I lost weight. I entered into a low-carb diet, per se, and I got pregnant. However, when I got pregnant, I had 4 early miscarriages before 6 weeks, and they were on my own. So I decided to do IVF, and I just wanted to know, what are the statistics with women who have PCOS getting IVF? I have 16 embryos. I have them PGS tested as well. So they made the final cut. I just wanted to know just a little bit more information about that.
How's your BMI now?
My BMI, I believe, my BMI is still high. My BMI is 35. So I recently lost like another 10 pounds. So I'm not sure what the new one would be, but it's 35.
Did the doctors do recurrent pregnancy loss workup on you? You cannot attribute it to just PCOS. So what did they find as the underlying causes of your 4 losses?
Nothing. I did the whole workup, did the whole panel. I think it was for like autoimmune, just things of that nature, found a histogram, HSG, things of, that nature, and nothing. I did an IUI. My last pregnancy, it It was the first one that was assisted, and I did an IUI. The IUI worked. I didn't make it to 6 weeks.
I think four unexplained losses doesn't work for me, respectfully.
Dr. Werlin, did you have a comments to add?
Yeah, I would just say that, you know, doing the workup is important, and obviously there's a great deal that goes on in the workup of recurrent loss. But in reality, probably of all the things that occur, probably 70% of all first trimester pregnancy losses are genetic abnormalities.
Yeah.
And
and I forgot to mention that. I did have my chromosome checked, or sorry, my embryo checked. When I did the IUI, we did a DNC, and I paid to get it tested, and it was a chromosomal abnormality. That's what they stated.
So the good news is that you've now done genetic testing on your embryos, and you now know that you do have at least chromosomally normal embryos, which is helpful. And, you know, in going back to doing frozen embryo transfers, ultimately, there's two critical factors that will play a role. One of those factors will be the embryo itself, and now you know you have normal embryos. And then the second factor will be your uterine environment. And typically, as I said, before we ever do a frozen embryo transfer, we typically will put the patient on the protocol to do an ERA test so that we have, you know, a good indication, number one, that her lining responds to the medication, and number two, that it gives us a clear window of when we should do the embryo transfer. So
Right.
I think those things are important.
Yeah, I think having the embryos tested, knowing that you had an aneuploidy for your last pregnancy is great. I heard that you did a sonohistogram, and I do prefer hysteroscopies, especially if patients have had instrumentation, a little bit more specific and looking for any kind of adhesions or retaining products. But knowing that those embryos are normal, if that was your issue before, I think you're probably in a good space.
Thank you so much.
So good luck.
Thank you, guys. I really do appreciate it. Thank you.
Thank you so much. Mia, maybe we can take the next question that you have on your list.
Yeah, all right. Yeah, so this question is from Tanya, who is 39 years old. She says, I was 37 years old when I had a miscarriage. I've also dealt with fibroids and had a myomectomy. I have stage 4 endometriosis and had my fallopian tubes removed prior to my first cycle of IVF. Following my transfer, I miscarried. I'm currently doing a 3-month course of Lupron in hopes of creating a more receptive environment for my next transfer. She'd like to know if there are any recommendations for women with endometriosis that have had a miscarriage.
Very good. We'll take the first who wanted to answer the question.
I have a question for her. There's a procedure called endometrial biopsy where a little instrument is put into your uterus, and when it takes a little piece from inside your uterus and it goes to a laboratory for special testing to see if there's an ongoing infection inside your uterus. Do you know if you've had that done anywhere along the way?
This was just a question we had submitted, so
oh,
we don't have any
sorry, I thought it was
information. Sorry.
Okay. So this is a uterus that had a myomectomy. The uterus was cut, the uterus was operated on, the uterus was stitched back up, and there could be inflammation or infection inside the uterus. There's a procedure where a little catheter is put inside the uterus through the cervix. A little piece of tissue is taken from inside where embryo implantation or pregnancy normally occurs. And we do special staining in the laboratory for plasma cell infiltration for infection. If it hasn't been done, it's something that should be considered. Endometriosis, you might, like I think it was Dr. Werlin who had brought up the ERA, endometrial receptivity assay, might be something that might be important to do prior to having another embryo transfer, if embryo transfer is in the works, because it does tell if your uterus is being properly prepared to have an embryo put in at the right time. I'm not a big fan of 3 months of Lupron therapy in endometriosis patients. I think sometimes there are other things that have to be looked at aside from that. I measure markers of inflammation in the blood. I think it's something that's a little bit novel. I don't know, maybe our other panelists can talk about it, but I measure inflammation markers. You have history of advanced stage endometriosis, that's inflammation. You have a history of fibroids and uterine surgery, that's inflammation. And there are markers of inflammation in the blood circulation that we can measure. And if you have high inflammation, there are treatments that we can give prior to an embryo transfer to normalize the inflammation. And I think that may be something that a lot of people don't look at, and maybe something that the person who asked the question can look into with whoever their practitioner is.
Thank you so much. Any other opinion in the panel? Very good. So let's move to the next question. We have a few more. We will take another question, Mia.
Okay, yeah, let me. So yeah, this question is from Annabeth. She says, I'm 28 and my first child was born on January in 2019. I had trouble getting pregnant, but actually conceived naturally. I haven't been able to get pregnant again since she was born and just went through my first round of IVF that failed in June. Just wondering how soon to try again and if the doctors would actually change any of the treatment. After the first failed IVF transfer, how long is it suggested to wait to try again? And if it's good to go with the same treatment plan the second time.
Very good. And this is for you, Dr. Jones. How long a patient should wait after a first IVF failure, and whether she should follow the same protocol?
Yeah, so it just seems like I'm not sure if she did genetic testing. Probably at that age she didn't. And although most of the embryos we would assume would be normal, we can't for sure say that that was a normal embryo that was transferred. So one failed embryo transfer usually doesn't ring alarms, though it is very distressful for a patient. It is something that is within the realm of possibilities. So as far as how long I wait, usually I let the patient cycle. There's not really, it doesn't need to be months. So 1 month in between to start up again. If there was any issues along the way, those could be adjusted. But I think for me personally, if we have an untested embryo in one failed cycle, but everything else was fine, including the lining was appropriate, progesterone wasn't elevated prematurely, which would have stopped the transfer, then using the same protocol would be an option. And also testing embryos would be an option as well if they weren't tested before.
Thank you. Can we get another opinion on the panel?
I just mentioned that I guess it depends on whether or not it was a fresh or a frozen transfer that she did. Again, from my perspective, we don't really do any fresh transfers because the one thing that you can't control in your fresh cycle is the uterine environment. The lining may look good on ultrasound, it may be trilaminar, it may be thick enough, but you really don't know whether or not hormonally it's receptive. Whereas in a frozen cycle, you control that environment and have the idea. Secondly, I'd agree with Dr. Jones in that I would just say from my perspective, I offer genetic testing for all of our patients who do IVF. And part of the reason that I do that, regardless of their age, clearly, if they're in any of the high risk groups like advanced maternal age, recurrent loss, previous history of significant male factor, previous history of an abnormal embryo, in any of those patients, I always, encourage them to do it. But even in the young patients, I do as well. And part of the reason for that is that normally you call up one dominant follicle. And effectively, when you do IVF, you're overriding that dominant follicle mechanism, and you're calling up all of those potential follicles that had the ability to develop in that cycle. So just like all of your partner's sperm aren't going to be normal, you're calling up eggs that never would have seen the light of day, ever. And therefore, their potential for being abnormal is real, which is why even when you see patients who use donor eggs, there's not an insignificant number of abnormal embryos in using donor eggs. So I would definitely agree with Dr. Jones and recommend that genetic testing would be a good idea. Doing a frozen embryo transfer where you can control the environment would also be a good idea.
Thank you so much. We have a participants live. Riley, if you can put Renee the call.
Hi, Renee, are you there?
Hi, how are you?
Good. Okay, you're ready to go now.
Okay, thank you. Well, this is my question. I had my first baby when I was 28, like 5 years ago. And after that, I couldn't get pregnant again. I tried for a year when I was 33. But well, then we decided to do an IVF cycle. So we did the first one, and none of my eggs were chromosomical and normal. So I did the second round of retrieval, and only one was good. So they implanted that one, and after the 9 days, they told me I was pregnant, which was very good news for me. But afterwards, like when they did the first ultrasound, they said that they had to repeat it again. So they did another ultrasound, and the thing is, I just developed a sac, but there was no embryo. And I was wondering, like, what could have happened if my embryo was tested? So I was wondering that.
Dr. Roseff?
When the embryo is tested, the embryologist takes some cells off of the embryo in order to analyze those cells, the chromosomes, the genetics in those cells. On occasion, the embryologist may, and I'm not implying anything about your embryologist, the embryologist may get close to the part of the embryo that develops into the baby. It's called the inner cell mass. There are basically two major parts to your embryo, the inner cell mass that becomes the baby, and an outer part called the trophoblast that eventually becomes something called the placenta. And if there was poor development of the inner cell mass, and that is usually described when the embryologist gives a grading to your embryo, it's usually letter grades, A's and B's and C's. If there was poor development of the inner cell mass, the part that becomes the baby, or in doing the biopsy of the trophoblast, if they got too close to the inner cell mass, and remember, they're taking a piece of a microscopic embryo, so it's really tough stuff. Then when pregnancy does occur, the part that becomes the baby, the inner cell mass, if it doesn't properly develop, then you can have this empty sac. I hope that makes sense.
Yes, it does, because the grade was actually very good. It was AB, I think. So
yeah, and even if everything went very well, sadly, I hate to say it, it could just happen. It does happen.
Well, one of the things that you might also just note is that when you look at when you do the genetic testing of your embryo, effectively you're looking at the chromosome makeup. Each one of those chromosomes carries about 1,000 genes. So the genome, or what this potential baby could be, is made up of about 25,000 genes. And so there are things that we just won't know. We may not know that this is a baby that was not destined to have normal lungs or normal kidneys or a normal heart. And there's no way you can test for that. And unfortunately, you know, even though chromosomally it may have been normal, there may have been some specific gene defect that we could not control.
You know, to add to that, to say that when we talk about embryos being normal, what we're really saying is that we didn't find anything wrong with them. Right. And so when I talk about, you know, this kind of testing, I talk about screening and prioritizing embryos for transfer. in a way that if we transfer the ones where we were not able to find anything wrong, we get better pregnancy rates than if we transfer embryos that weren't screened, or certainly if we transfer mosaic embryos or embryos that were shown to have chromosomal abnormalities. So it's not the same as if we're testing for a particular mutation where we have a very good idea of whether that mutation is present or absent. It's really putting the embryos through a sieve and trying to find the ones that are the best.
Thank you so much. Any other comments, Dr. Jones? Do you have any other comments? Very good. Yeah. Let's release the poll. We have asked some questions our patients, and let's look at the poll results. William, can you run us through the poll?
Yeah, so the poll, the first question that we had asked was, are you currently seeking any fertility treatment? 53% of the respondees said yes. The second question that we had was, is this your first attempt at IVF? And 70% of patients had said no. The third question that we had asked was, are you satisfied with the amount of information that you received from your provider? And 41% of people said somewhat, 37% said yes. And the fourth question that we had asked was, what are your expectations with your ongoing or future treatment of IVF? And 48% said that more information on their treatment in order to help them understand their success rate. And following with 37% of people responded with conceiving during their first treatment. And 33% said better communication and support from their doctors and clinics. And that was the poll.
Thank you so much.
You're welcome.
Any feedback from the panel on the poll? Any surprise?
Well, I would comment that during this pandemic, it has been helpful to actually state to patients, especially because we're doing so much virtual consulting and that kind of thing, that it is more challenging to go through treatment now than it would be without the pandemic. And just talking about that seems to have helped in that patients will then come to me and say, you know, I really hadn't realized how much this was stressing me out. And clearly, fertility treatment stresses patients out, but fertility treatment and COVID is just a bad combination. And part of it is because we're not seeing the patients in person as much. There's less hugging and reassuring and all that kind of thing. So I think it's helpful to validate that experience.
Thank you so much. Any other comments on the poll?
I would just echo that sentiment. In our office, we're limiting partners. I think that's very stressful for the patients. I do think that telemedicine offers something, but when you're in the office, I like to draw pictures. I really feel like I can have full attention of the patient where, you know, dogs aren't running around, children aren't running around, and, you know, we really maybe can just explore things a little bit more deeply. And so, yes, COVID has been a tremendous stressor for our patients. And I am not surprised by the sentiments of feeling like they're less informed, because I think there's less contact because we are trying to limit some of the contact, and I feel like there's more patients. So, you know, I completely understand.
Very good. Any other comments before we go into wrapping up the webinar? Okay, so this is just a last poll that we're gonna ask the patients to see their feedback on the webinar. I wanna take a minute and give you guys time to introduce your practice and tell us what you do for the patients. And I will start with Dr. Roseff first and go in the same direction.
So my name is Dr. Scott Roseff. I am board certified in reproductive endocrinology and infertility. I did my specialty training in San Diego, California, and I have been in practice for 31 years. After I finished my training, I was recruited to be the founder and director of St. Barnabas Medical Center, the IVF facility at St. Barnabas in New Jersey. And that was in 1989. And I was in New Jersey for 17 years. And then I was recruited to come to South Florida thereafter. My practice, IVF MD, has a website, ivfmd.com. We have 6 office locations. We have 12 doctors. We do over 1,400 IVF cycles a year. So we have a big practice, but we maintain among the highest success rates because even though we do a lot of IVF and it's a big practice, we pride ourselves on very individualized, personalized, one-on-one care. For example, I spend 90 minutes, I spend an hour and a half with a new patient consultation, and my follow-up visits are 45 minutes. So I take a holistic approach. I integrate alternative and complementary therapies into the practice. And what I do with every patient I see is, number one, I see if I can make a primary objective for them to conceive on their own without having to go through any kind of assisted reproduction. Find out what the problems are, what are the challenges, level the playing field so that hopefully someone can conceive on their own. If they don't, or if it's not in the cards and they need to go through treatment, then I always take a half a step back, dot a whole bunch of I's, cross a whole bunch of T's before we do something like in vitro fertilization, so that when you do in vitro fertilization, it's going to be the best chance of success right out the gate. Most of my IVF patients conceive on their first IVF cycle, which surprises a lot of people. My motto has always been do it once, do it right, and just make it work. So that's me, and that's my practice. And we're in South Florida if anybody's interested. We do offer free second opinion as well if we get medical records from a previous practitioner, if anyone's interested.
Thank you so much. Dr. Rodi?
Yes, my name is Larry Werlin. I am a reproductive endocrinologist. I was the 3rd National Fellow at the National Institutes of Health, finished my fellowship in 1982, and have been a practicing fertility specialist since then, 38 years. I was initially a faculty person at the University of California at Irvine from 1982 to 1986. And then I set up the Hoag Fertility Center, fertility services from 1986 to 1995. And then became the medical director of Coastal Fertility since that time. Dr. Rodi and I were actually part of the first study that ever looked, first randomized prospective study that ever did genetic testing on embryos. And we published that data back in August of 2003 in Fertility and Sterility. So we've had a long line of work that we've done in genetic testing of embryos. I would say that I'm a very hands-on person. I see all the patients that come to see me. I'm the person who does their ultrasounds. I'm the person who does their egg retrieval. I'm the person who calls them with results. I deal with them on a one-on-one basis always. And we've been doing that ever since we started seeing patients. I love medicine. I love reproductive medicine. This is what I do. I'm one of the few people who likes to get up early, come into the office, see our patients, do the work. I'm in a group of physicians who, when we went to medical school, was the peak of Vietnam. And so the only real deferment at that time was medical school. So there are many doctors in my age group who are not very happy with what they do because that was their only way to not go to war. I was not one of those people. I was very excited about being a physician and very excited about being a reproductive endocrinologist. And I want to thank you for allowing me to partake in this seminar, and I hope it's been beneficial for y'all.
Absolutely. Thank you so much. Dr. Rodi.
My name is Ingrid Rodi, and I was only a few years behind Dr. Werlin at Harvard UCLA for my residency and then for my fellowship. 35 years ago on July 1st, I started in private practice. I've always had a relationship with UCLA, and for 5 years I was full-time, and now I'm in a private practice in Westwood, California, Pacific Fertility Center, LA. We do the full gamut from very low tech to a lot of LGBT cycles with donor egg and surrogacy and donor sperm. A big international practice when people are allowed to travel that is now to a large extent on hold. And I enjoyed teaching fellows and residents. So it's been a great career, and I've enjoyed it just as much as Dr. Werlin has.
Fantastic. Thank you so much. Dr. Jones.
Hi, I'm Dr. Tiffany Jones. I am originally from Los Angeles, California, and Dr. Rodi, we have something in common. I did 10 years of research at Harvard UCLA, so I'm very familiar with the bungalows over there. I went to USC for residency and Mayo Clinic for fellowship. I'm in my second year of private practice. I'm with Conceive Fertility Center in Dallas, or rather Irving, Texas, with Derek Haas and Dr. Julian Escobar. Our practice is, the goal of our practice is to empower women to seek care and not to let affordability be a barrier. So we are also offering free second opinion consults, and we have discounted our IVF cycles due to the COVID pandemic to partner with our patients to allow them to continue care or seek care if they weren't able to do so in the past.
Thank you so much. I know we have had some other questions that we're not able to answer today, but I promise you that we will answer them next webinar in 2 weeks. This is the result we have received as far as feedback. We asked the audience if we have solved or answered some of their concerns, and 68% said yes, 25% said somewhat yes, and whether they wanted to see this webinar in the future, this kind of webinar. 86% said yes, 14 somehow somewhat. This is because of your expertise and your dedication and your support to patients. We thank you for that. Next week, we will be having another webinar. This time, we're gonna address the artificial intelligence for embryo selection, a new trend in technology, and how is it used to improve clinical outcome. With this, I would like to thank every one of you for giving us your perspective and expertise in the field of fertility treatment. And I will see you next week, Wednesday at 3 p.m. Pacific time. Thank you so much. Thank you for joining us.
Thank you for having us, Progenesis.
Thank you.
Bye-bye.
Bye-bye.
Thank you, bye.